groups running next week.
Sorry.
That's okay. So that is broad strokes what I'm doing with my time right now.
Awesome. Busy.
Yes.
Loving it. Well, and what drew you to working with neurodiversity, and how'd you kind of end up there?
Yeah, I always have a hard time answering that question. I think a lot of different things. So my mom is a special education teacher. So kind of from the beginning of my life, it's always been something, education and just being aware that we are all made differently, has been just kind of a part of my life from the beginning. And then I think in undergrad, I really was open to what I could do with my career and really work with different populations. And this was always the population that I kept coming back to, really seemed to connect with, and just really enjoyed my work with them. So in graduate school, I sought out opportunities that allowed that. And here we are.
That's awesome. Well, we're excited. We'll just kind of let you dive in. I know we had sent over a long laundry list of questions. And so
They're really
so
great.
I know, and it was cool to see like, oh, there's a lot of interest in this. And obviously, you know, when I had asked in our last all staffs, Eastside and Seattle, who was, you know, who had clients that maybe identified as that or were curious about that. I mean, almost everyone raised their hand. So obviously a relevant topic, which is great. And so you can kind of, you know, share what you wanted to share with us. Hi, Kristen. And then we'll take time to get to as many of those questions as possible. So really the floor is yours.
Okay. I have a little bit of a PowerPoint that I'm gonna just use to mostly guide me. So if I'm looking off to the side, that's what I'm doing. So looking at all of your questions, I really wanted to make sure that I covered all of them. I think that I did in my presentation, but if not, I'm gonna leave ample time for you to answer any questions that I missed or anything that comes up while I'm speaking. But for sure, I'm going to talk about what it means to have a neurodiversity affirming approach in the therapy room. And then a little bit about like differential diagnosis, things to consider. A little bit about the assessment evaluation process, and especially like when you should consider or how you should talk about that with your clients or could talk about that. And then just different things that I think are important for therapists to know that you may already know a lot of this, but I'm just going to kind of have us all be at the same space when we kind of enter into like the discussion section. So one of the main things that I think is important, or that I will bring up with people when they ask me, you know, why this work? Why do you think that it's important? And one of the things that I usually say is that it's very prominent. There's a lot of people who fall into this category, especially when you look at the broader definition of neurodivergence. That includes things beyond autism, ADHD. There's a little bit of argument about what that means, but for the most part, it really just means people with non-typical neurology, which, I mean, typical and normal and all the things. So that's where the debate becomes and gets really complicated. But really, it's just the recognition that we all are wired a little bit differently. Some of us fall into different categories that are a little bit more, you know, we can name them like ADHD, this is what this looks like, or autism, this is what this looks like. But really just honoring that and not pathologizing that. Not having that be something that's wrong or needs to be fixed, just something that really, let's help you understand what that means. And so I can also understand what that means. And then how do we solve everyday problems together, just like you would with any other therapy client. Some of the more recent estimates for prevalence are, I think 1 in 54 in the United States or something like that. So like 170%, 178% increase from, I don't know, like 5-10 years ago. There are a lot of different reasons why. I think one of the major ones is that we're finally really understanding what it really means to be autistic or to have ADHD or any number of these things. We're getting so much better about recognizing things earlier and helping people and really having just interventions and like the supports there for people so much earlier. And we're also finally putting money and energy into research and understanding for females and other parts of the population that were just missed or overlooked for lots and lots of years. So the majority of the research, I would even say like pre-2005, is pretty heavily white male. And everything after that is starting to be a lot more diverse. So whenever you are looking at research, just be really mindful of what population they are basing that research off, because a lot of times it's heavily skewed that direction. In my understanding of neurodiversity affirming care, I think it looks different for everyone. But essentially, it just means like it's a form of cultural competence, essentially, that you're just taking steps to be aware of, to educate yourself about any possible biases that you might hold for these populations. And then for you to just have appropriate knowledge for treating them. You don't need to be a specialist in one of these areas in order to work with these clients. You just need to make sure that you're not doing harm and perpetuating internalized ableism or, you know, a lot of the different wrong information that's out there. Because at the end of the day, you'll be treating them or working with them for pretty similar things to everybody else, anxiety and depression and all of those things, relationship issues. There's just a little bit of a different lens sometimes that you have to frame your work through or your case conceptualization through. I wanted to talk a little bit about diagnostic considerations, and it sounded like from your questions, you also had some questions about how do you tease out when it is autism or when it's complex trauma, or if there's some sort of other like behavior or conduct disorder. I think the simple answer is it's not easy. And then to look at the etiology of it, where is it starting from? I think it's still true that autism and ADHD specifically are one of the things that sets them apart is that they are neurodevelopmental, and by that I mean there's something that like people are born with them. That's who they are. That's the way that their brain is wired and the lens through which they experience life. Anxiety is something that in some ways I guess could be true, but it's something that when it reaches disordered level, it's something that they probably developed over time or at a later part of their life or in response to some sort of experience. Sort of the same thing with trauma. It's often an event, series of events, an environment that created this these responses, and that makes it different. Sometimes they can appear the same, but usually when you dig a little bit deeper and really figure out, okay, like this wasn't the way that you were when you were 5 years old. This wasn't the way that you expressed yourself when you were 10 or 12. This was something that when you were 16 started to develop. This is something that when you were 24, you realized X, Y, and Z. So that's a lot of the time where the difference is. I think the other place is where it tends to not be so global of an impact. I guess that's not always true in things like complex PTSD, but somebody who's autistic, they show up autistic everywhere all the time, unless they're masking. That's a separate thing, but it permeates their life because it is who they are, just like I am who I am everywhere that I go. So that is different when maybe you're experiencing anxiety. That might not be something, excuse me, that the symptoms get triggered every single situation that you're in. It's in response to social situations, or maybe a specific phobia or something like that. The other thing that I hear much more than I'm comfortable with is people really having a I get asked this question, is this person a narcissist? Like, why does it seem like they are, so focused on themselves, so, single-minded about these things? And I think that's another place that autism can sometimes get overlooked, is it can appear and it can feel a lot of the time that there are traits of narcissism present. And I think we have to be really careful to make sure that we're knowledgeable and understand the differences, because those are two very different things and two very different treatment paths. I think the same thing with behavior and conduct disorders, especially in younger kids. I hear a lot of the time, like it's behavior, they're just, a hard kid, or I don't know, any number of different things. But when you really look at what's going on, they're struggling to get their needs met. They're struggling to express themselves and have their environment understand what they need and what they want. And that's why they're having a really hard time. And this is what the end product is. But if we can meet their needs and figure out how we can help them, then I bet you they're gonna be a lot better. And often that is the case. So I think those are probably the four main things that I see when I'm speaking, especially to somebody new who I don't know, or we haven't learned each other yet. I'm kind of thinking about, like, what are these different things that could be present if it isn't autism? Because a lot of the time symptoms or traits look really similar. And it just takes a little bit of understanding and a little bit of investigating to tease them out. I also get a lot of questions about a lot of the things that we're learning more and more about. So sort of like the uncommon autistic traits. And I say uncommon in quotes because I don't think that they're actually all that uncommon. I think we just don't know very much about them yet. And we're learning more and more about what they mean and how they show up and why and all these different things. So one in particular that I'm finding I'm working a lot more with a couple of different people is alexithymia. It's not, none of these things I don't think are really specific only to the autistic community, but they show up quite a bit. And this one in particular has been a struggle to work with, because it's all about like understanding your emotional experience and then expressing that emotional experience. And it's really different from somebody who is just having a hard time like tapping into their emotional experience because of trauma or some other thing that they're struggling with. It's an actual inability to really understand and like connect with their body and what that emotional experience is. And that causes a lot of distress for people. I have people who are really like want to be able to do that and struggle to communicate why they're feeling what they're feeling, and get misunderstood a lot, get miscommunications happen a lot in their relationships, and it just causes a lot of issues. And so we're working a lot to practice like naming. I'll name for them a lot, like, it sounds like you might be experiencing some grief, you might be sad. And a lot of the times they're like, I guess. And we'll talk about, why I might say that, why it seems like that situation that they're describing to me would make somebody sad, and then try to see if that really is their experience or if maybe it's something different. So that has been a really interesting challenge to treat and try to learn how to treat. It's also something that is not very well researched. There's not a lot of like assistance there. I think there are a couple of programs that I have yet to take. And there definitely is some good stuff out there. There's just not very much. Apraxia is also something that shows up in this population that just really has to do with disconnection in movement and motor skills. That doesn't show up so much in the therapy room necessarily, but it might be a challenge that a client is experiencing and just struggling with and trying to figure out, I think this is also one of the areas where a lot of like shame and internal self-esteem and things like that can really show up in the therapy room around like looking different or being different or having different abilities. So really understanding and helping people, empower them and work through some of that stuff is probably where that shows up the most in the therapy room. I also have quite a few people, this isn't necessarily very common, but I think it's more common in the autistic community. I'm going to say the word wrong, pareidolia. Essentially, it is thinking in pictures or having highly attuned pattern recognition ability. I have several people who are in the, thriving in their careers in the tech world because of this, innate ability that they have to just really quickly understand like that's wrong, that's off, and why, and then be able to kind of like go in and fix it. And so that's one of I also have somebody who kind of talks about like once I have a card, I think is how they call it, it's really hard for me to rewrite that card. So I'll think about it and visualize it as like that picture of a card. And so once I have written that card, it's really hard for me to overwrite it. And so what happens is I create two cards. There's the original card and the secondary card that is the correction of the first card. But that's why I have such a hard time when people ask me a question, coming up with something to say right away, or why it looks like I'm struggling when I'm speaking with them, because I'm internally trying to, I see the first card, then I see the second card, and then I have some anxiety about like, oh no, I'm taking too long to respond. And it kind of like turns into this like whole internal experience that creates a lot of distress. PDA or pathological demand avoidance is another one that shows up a lot. Usually I don't see it as much because I'm not working with kids at the moment, but it, for the most part, I would say, I think gets first recognized when somebody is younger, just because it can be difficult if misunderstood or if you don't know that that's what's going on. And even when you know what's going on, it's kind of tied into rejection sensitive dysphoria, but having a really maybe narrow window of tolerance for rejection, perceived rejection, a demand that you don't understand or don't understand the importance of. I honestly don't know as much about PDA as I probably should. But rejection sensitive dysphoria shows up a lot also in ADHD. So I see that one a little bit more. And so
can I ask a question around
Sure.
that? Because
Yeah.
one of my clients who has autism, he and I have been talking about this quite a bit, where he was like, RSD is something that like just clicked with his experience around like the emotions that he sometimes has to deal with his partner and all of these different things. And I tried to do some research on my own. And one of the things that I found is like, some people are like, yes, this is definitely something that happens with the autism ADHD community. Other people, it's like, oh, well, it hasn't been researched enough, so we can't. I just wanted to ask you a little bit more about that and just see, like, in your experience, like, kind of bringing up that topic, how has it been? Are there any other resources or places that we might be able to check out more about that?
Yeah, I mean, I think the thing is, I think research needs to catch up, because when you talk to people like your client or another client that matches their experience to a T, and they are like, yes, that's me, that's what I'm experiencing. Just because we don't have research to back up that it's real doesn't mean that it's not. It just means that we don't understand it. And so I will usually talk to people and kind of explain that, like, that doesn't mean that that's not your experience. Unfortunately, we don't know a lot about what really is going on or why, but I can work with you to have it not impact your relationships as much. It may not be something that goes away, but we can, one, kind of provide some education for your partner, if that's the context of how you're working with them, about like, this is what's going on more often than not. So reacting to like their first reaction, maybe not super helpful. Let's all like take a step back and allow them to process, allow them to use some of the coping skills that we're working on, allow them to use some of like maybe DBT skills that we have introduced, and then maybe tackle the problem. And working with your client to also recognize that that's what's happening in themselves, to give themselves pause, to like name it, like, okay, this is probably some RSD happening right now. This is not her, him, or whoever, my partner rejecting me. This is me feeling like that's what's happening. Let me check in with them first and see if that is really what's happening. And then I can react to it or not. And we can have a conversation about what is happening instead. Takes a lot more work. It's a lot slower. It's a lot harder, but I think that it definitely can be helped. I have some books that I'll probably show you guys later on. I don't know that any of them have anything specific to this though, if I'm being honest. I think along this line, there's similar conversations around being a highly sensitive person. That comes up a lot as well, that like profile. Sometimes I think it does. I don't know. There's debate about whether or not it is, and it's just autism that's not identified, or if it can be its own thing. I don't know. I don't really know what it really just you need to know, or we need to know, is that that person has much more sensitivity maybe than like or attunement maybe to others, to their environment, to the things that are going on, that can be a gift, but can also be a struggle. And so kind of helping them weigh those things, have more effective boundaries around probably certain people, certain places, really attending to their sensory needs and all that kind of stuff, maybe even more so than somebody who doesn't like more identify with that profile. I think that's all I want to say about all of that stuff. I feel like I'm talking really fast, so if you have any questions, please let me know. But otherwise, I'll just keep going, and then we can talk afterward.
No, this is great.
Okay.
And maybe we'll get to this eventually, but I was curious, like, if someone actually has autism, but it can get sort of misinterpreted as narcissism. I was curious, like, what's going on for an autistic person that's like showing up that way?
Yeah, I think I see it the most when it is an autistic male who has a lot of trouble with like all or nothing thinking, who is struggling with like flexibility in changes, and sometimes also is really, really smart, and they do know a lot of things about a lot of things, and can like tell people when they're wrong, but maybe their delivery isn't super easy to receive for other people. And it can get misinterpreted as manipulation, or I think it also can be experienced as verbal abuse or emotional abuse. I don't think that, you know, I can't take away from that probably is how it feels, but what's happening behind the scenes is different than somebody who has narcissistic personality disorder. So I think there's a lot more in, if that person is autistic, there's a lot more psychoeducation for all the parties really about why this might be happening, why this person might be struggling to connect with you in the way that you're able to receive, and then talking to the client about, okay, when you show up this way, you can show up this way, but when you show up this way, this is probably how people are going to respond because it comes off this way. And it's kind of a discussion then about if you're okay with that or not. You don't have to change, but this might be a little bit difficult, and it might be why your partner or your child or et cetera are having a really hard time with the things that you say, the things that you do, and why they're reacting in such a like big reactive way, because it feels like a boundary violation. It feels like you're trying to, whatever it is. Does that make sense? Did I answer your question?
Yeah, I mean, narcissists can be very inflexible, so that makes a lot of sense, right?
Yeah.
You're right. Like, I think I've even experienced it, like it feels different, even though it looks very much the same.
Mm-hmm.
Experiencing it as the clinician. So
yeah. And I think that's some of our maybe the gift of our job. I don't know how you want to talk about it, but we see so many different people and we're exposed to so many different things that we do have a little bit more of a sense, I guess, of how when somebody is showing up one way versus the other, it feels very different. And that might not sound super, scientific, but it does, it means something. And because we have that ability to, help somebody understand, like, this is different, and this is why, and this is why we're going to approach it this way rather than this way. This probably won't work very much because that's just not who this person is. Give me some time and let's see if this can help. And a lot of the time it can. And I think there's also some relief sometimes in that person feeling understood for probably the first time. And they can also see things shift a little bit. It might be a little bit of a tough road, but when things start to shift, when people feel more understood, it generally is a better thing.
I have a question too, while we're still like so close to the topic. Just thinking about the complications with like being able to identify or communicate feelings. And I think like what I have been doing, which I don't know if this is like the right thing. I think it's something that my clients have appreciated, but I almost feel like when I'm working with folks who have autism or are on some kind of like spectrum where their brains just process like emotions in a different way. A lot of my clients who are autistic really, really struggle with like if I show them a feelings wheel, it's like, I don't know what to do with this. Like, what even is this? And instead I hear a lot of like, I feel itchy. I feel sticky, you know, and so like I tend to lean towards like, okay, let's stick with the language that's true to your experiences of going through and like navigating everyday life. And then I kind of focus on like, how can we more effectively communicate to others requests for them to try to understand like how we experience the emotions. But I was just curious about that. So like I do a lot of visualization where it's like, you know, if your emotion had a color, what color would it be? If it had a size, what size would it be? And I've gotten a lot of feedback from those clients who are like, this is great. Like, this is one of the ways I've been able to express myself as clearly, you know, than potentially ever before. But I'm wondering too, because you were kind of talking about like doing that like emotional literacy work, but I wonder if in your experience, you've been able to do that work in a way that does make some of the like, you know, angry, surprised, like ways of expressing feelings and emotional experiences connect better, so that like maybe you're working with someone who initially, you know, like has no idea what to do with the feelings wheel, but then potentially throughout your time together is actually able to find that somewhat accessible. Because that's like a thing that like I'm definitely not doing with my clients. And I don't know, I would like love to know what your experience is and how you do some of that like emotional literacy work.
No, I think what you're doing is great. I think that is a very accessible approach to connecting with the experience of emotion that is so foreign essentially to some of these people who struggle with it, because it's just not something that they're really able to do. It's happening and it's there. It just feels maybe different, or they're just not recognizing it as that. And so I think that's maybe what I would do with that, with your approach already, which is a very beautiful one, by the way, would maybe be connecting it to then like, that sounds a little bit like sadness, or that sounds a little bit like anger. And whether or not they always feel like that is true, I think it helps work that muscle a little bit, but then it also helps them maybe understand or be able to communicate something that might be more relatable to the other people in their life, that, you know, can help with the communication piece of of emotions, because a lot of the times it's in relationship with others that can become a problem. So knowing that, you know, the thing that I'm feeling right now feels really red, and that sometimes means that I'm angry. Okay, what might I be angry about? Okay, they said something that I didn't like. All right, how do I want to approach that now? So just helping them weave the thread maybe a little bit is how I would describe it.
Thank you. Yeah, that's really helpful. And I'm even just, it's like, it's something I haven't really like pushed or tried to be too present about, just out of fear that it's like not going to be helpful or will just be like more frustrating or invalidating. But I can also imagine kind of with what you've shared, like really lovely ways of getting practice on how to communicate different emotional experiences, where for me to even share like, oh, that sounds kind of like when I'm feeling this way, and it being able to just be like a nice, you know, mutual learning experience of like, oh, that's what emotions are like for me, that's what they're like for you, right? So yeah, thank you so much.
Yeah, I think there's also sometimes some relief in like, oh, okay, I'm not, you know, whatever they've attached to that. Like I've had people be like, I think I'm just crazy. Like, I don't know. Or I never know what's going on with my body or with, you know, the communication issues that are going on. Like, I just don't know. And I think there's a lot of relief when they can understand just a little bit, when they can understand when you react this way, it's probably because you're hurt, or when you react that way, it's probably because you're angry. And it's just like, it helps them have a place to then like, yeah, okay, yeah, you're right, that is what's happening. And now I can like work on ways to advocate for myself. I can work on ways to avoid that situation. I can work on ways to whatever. I think the next thing I wanted to talk about was assessment and evaluation. I get a lot of questions about, and I think this was one of the questions in your list, about when to refer. I don't know that there's a wonderful answer for that. I think whenever somebody feels like they want more information, or whenever you feel like you want more information, would be a good, step one. Especially if you are just running into a lot of roadblocks, or just really aren't feeling like whatever it is you're doing in the therapy room is touching the situation or changing the situation that they're coming to you for. I also have a lot of people who, and the research is sort of like backing this up, that who have been wondering about whether or not they are autistic. They've done a ton of research already, and they are like, I think so, but I don't know. And I don't want to, trying to think of the word that they use, like impose themselves on that community if it's not really like their community. But more and more, the research is showing like, if you think you are, and you've done the research and you still think you are, it's pretty likely that you are, because your internal experience much better than anyone else. And more likely than not, they are being more cautious than they need to be about, misidentifying themselves. That may be changing with TikTok and all the things becoming more popular. I don't know, but at least in the people that I am working with, that has been most often the case. Like, by the time they reach my office for an evaluation, I can't believe that this has not been a conversation that they've had with somebody before, ever. And two, it doesn't take very long for me to recognize, like, absolutely, and you were right this whole time. And okay, now what do you want to do about it, if anything? I think the when to refer question also maybe only becomes a real challenge in that there are just not that many places to refer someone who wants, especially an adult, who wants an evaluation. I, a lot of the time, will talk to people who have spoken to 4 or 5 different people, and either they don't, or their waiting list is unbelievably long, like years. And that sucks, and that's awful. And I don't know necessarily what we can do about it, other than like keeping going on and offering as much services as we can. But I also think that's where the therapy room can be helpful. You can maybe be that person who is the first person to say, like, hey, do you think this is maybe what is going on? This is how I would describe what you're talking to me about. And then have the conversation about, you don't necessarily need to be diagnosed. It's not something that you have to have. If it's something that you want, though, I can refer you to somebody to get that definitive answer, I guess. That being said, I think that looking for clinicians who are practicing from a neurodiversity-affirming lens, who have some evidence somewhere, either through reputation or on their website, that they are moving beyond the medical model of autism, and aren't going to say something like, well, you have a job and you have friends and you're 40 and you seem to be doing fine. So that's not what it is. Unfortunately, I hear stories like that a lot. And I think, I don't know that, I don't think people are necessarily trying to do harm, but benefit of the doubt that I'm giving them. But I think that it's important that you're referring people, clinicians who specialize in this, if at all possible, or at least have a little bit more experience. Somebody who doesn't do these all the time, who is just kind of like a more broad clinician, maybe they're out there, but I don't know that they necessarily are always the best equipped, especially in cases that are maybe a little bit more nuanced, or that person has really, really low support needs. Like they have been like killing it at life, except for a few things, and are just wondering why their experience has been just a little bit different than everybody else's around them, or a little bit harder in certain areas. Those people, I feel like, are the ones who usually get like dismissed or turned away. So that's what it's my like little soapbox. I'm really passionate about working really hard to not be that clinician, the one who I try really hard to allow people the space to just tell me their story. And a lot of the time they're right. So believing them, and not just dismissing them, I think really important. And then I think the only other thing around evaluation that right now I want to say is just walking people through what to expect. A lot of the time people will come to me and just have any idea. And I think that causes a lot of anxiety for them, and sometimes delays them reaching out to people. And the answer just is pretty simple. Like, it's, especially with me, I can only speak to my own experience probably the most, but it looks a lot like just a conversation. It feels just like a really long therapy session, sort of, because I am running through their almost entire history, and I'm asking about all of the different areas of their life. And I kind of describe it to them at the beginning of the interview, that it's just going to feel a little bit like a really long job interview. And I'm just really interested in knowing about your life and about your experiences and what it was like for you in school, and why you've changed jobs 4 times in the last 2 years, and all of these different things, because it will just help me. And then I'm using the MIGDIS right now. I've also used the ADOS in the past. With adults, the ADOS is a lot less stellar. It misses a lot of people, and is really, it's very rigid. I think it can be a great tool, and sometimes is a necessary one with younger people, because that's a lot of the time what schools and things are looking for. But if I don't have to, I don't use it, because the MIGDIS is a lot more affirming, and pays attention a lot more to sensory experiences and things like that. And then I'll just tell people after that, I'm probably going to talk to your therapist if you have one. I always talk to at least one other person in their life. I prefer it to be somebody who they've known for a while. Sometimes it's a parent, sometimes it's a spouse, sometimes it's a sibling. I've had less ideal, but roommates and best friends and things like that. But then I'm going to take all that information and put it together and see if it matches the profile of somebody who's autistic. And then we'll talk about what that means. And I have some recommendations for moving forward, and that's kind of it. It's a long process, at least with me, because I take so much time. But I think that I think people find it, the feedback that I get is that it's helpful, and that people feel like I do a thorough job, and I'm not missing things. And I think it a lot of the time, by the time that we get to the feedback session, I'm confirming what they already sort of know, and there's a lot of like relief in knowing. And then it kind of just becomes, the feedback session kind of just becomes like this conversation about them understanding themselves better, and the relief of kind of like having things match up and having some increased self-understanding. And that's kind of really it. Like there's nothing necessarily to change from there. A lot of the times, like my recommendations are, keep doing what you're doing because you're already in therapy, but just let your clinician know so that they know like this is a part of what's going on. Yeah, I think that's about it. The next thing that I wanted to talk about is kind of related to that. Some of the things that I think are important that not all people know, just because you're not like in the community maybe, or reading all the research or whatever, but I think that are important to know as a clinician who may or may not come across a client who is autistic, is knowing the debate or the sides or the things around language. I pretty intentionally use autistic person instead of person with autism or ASD. Like any population, it's, not everyone agrees, but the vast majority, over and over, when autistic people are polled or spoken to or asked, there's a strong preference for identity first language rather than person first language. So instead of person with depression, person with autism, they prefer autistic person, because it is who they are. It's not something that is separate from them. So that is a pretty strong preference, and you're going to show yourself pretty quickly as not maybe knowing as much as maybe being a super safe person for them if you show up that way, which again, not everyone will have that reaction, but definitely some will, and it will be a very strong reaction. So just kind of knowing that. Same thing with ABA. There is a very big preference for not ABA, against ABA, especially within the autistic community. A lot of the pro ABA dialogue and message is outside of the ABA community.
I'm sorry, what is
sorry.
ABA?
Yeah, it stands for Applied Behavior Analysis.
Okay.
It is very derived from like basic like Skinner behaviorism, like bare bones, this, that equal gets this result. It definitely has changed over time, and I do think is trying to be a little bit better, but still by and large the preference is to not. That being said, I have clients who are in ABA, and I don't shame them for it. And I just ask them to help me understand what their experience is like, if they, experience it as affirming, or if it's something that they're feeling they're being forced to do by a parent, and then we might have a conversation. It's tricky. And it's probably a little bit case by case, but overarching, that's another thing that it's generally not a very affirming intervention. And then there is also a newer movement around the language of autonomous versus independent, especially, I don't know, 10, 15 years ago. There was this push for wanting really anyone receiving services to become independent, to that was the goal, to do all of the interventions in order to help them achieve independence. And more there's this shift to autonomy or being autonomous. And really what that is that independence is more about not needing or not accepting any assistance, or not being dependent in any way to anyone or anything. And that is not a reality for probably anyone. And it can be a little bit shaming too for people who do need help or do need assistive technologies, or, an accommodation at their workplace or something like that. So to talk about it as, what things do you need in order to be more autonomous? Is it a little bit more flexibility in your work schedule? Is it, an assistive technology to help you communicate? Is it, whatever it is, that is a much more affirming approach, and a much more realistic one as well for anyone, because no one can do everything completely on their own. And then I think the last thing here is I wanted to talk a little bit about masking. There has been, I think with the publication of a couple of new books, like Unmasking Autism and one other one that I don't remember the title of right now, there's a lot of discussion around the role of masking, the utility of it, the harm that it's created, the expectation that there is sometimes for autistic or neurodivergent people to mask it and cover it up and not, to appear neurotypical in order to gain acceptance into community, or to not cause waves and at work or whatever it is. And a lot more understanding and recognition of the toll that takes on a person, and kind of how that ties into things like autistic burnout and internalized ableism and lots of other things that can be really harmful, but also, understanding why it's happening, that for some people, sometimes it's helpful, not taking a 100% universal anti-masking approach, because I think some people find that they have to in order to be safe at work, for example, but just helping them understand it, navigate it, even just complain about it sometimes, because it can suck. But also normalizing a little bit. Mm-hmm.
What are they masking, or how? To me, it feels impossible for them to do that. So I'm because it's so much about what they're experiencing. They're masking what they're experiencing.
Yeah. So I think things that fall into masking category is really suppressing the urge to stim, really faking or forcing themselves to be outgoing, extroverted, and like go-getter, kind of like involved at work, which may work and may be fine, but what's happening underneath that is it's like so much energy for them to show up that way that then when they get home they're just like depleted and there's nothing left, and that's where like the harm of it comes from. I think it's also like this expectation, there's this expectation behind it, like they have come to understand, or their understanding is that I can't be accepted if I'm not looking at people directly in the eye when I speak to them, or I'm not turning down my desire to talk about like something that I really care about, or I'm not like basically like dimming my light in of like the thing that who I want to be and who I want to like show up in certain situations. They're like taking cues from their experiences over time and their environment and like really trying to fit inside this box of who they feel like they should be, and then sometimes who they're expected to be. And that's sort of like what they're talking about with masking. I think sometimes, yeah, sometimes it's not possible. And that has its own benefits and issues.
It almost seems like an introvert pretending to be extroverted in like at least the
Yeah.
ways.
Yeah.
That's exactly it. But
yeah, I've had some clients talk about it like that, pretty much. Like I will be an outgoing, presentation giving, networking professional, but it's so hard for me and I don't want to. And what I would rather be doing is this, or even sometimes I enjoy it, but it seems like it takes so much more from me than it does my colleague. And it doesn't come natural. It's something that I have like mimicked from other people over time, that I have observed. I have a lot of clients talk to me, especially like when they're in like adolescent years, they'll like be like the social scientists, essentially. Like they're looking to see what other people are doing, how they're doing it, and they will literally tell me they'll go home and spend hours in the mirror trying to do that thing in a way that looks natural, because they are so much wanting to or feel like they have to, and it's kind of like deconstructing that, like, yeah, that was something that helped you adapt, it really served you for sometimes, and still sometimes it serves you. Is it something that you want to continue doing or need to continue doing? Are there ways that you can stop doing it in certain areas of your life so you feel like you can be a little bit more authentic? I feel like those are probably like the most common conversations I have with people around masking and stimming.
Yeah, I experienced that with clients that like have experienced a lot of like social rejection or like bullying, like social trauma, essentially. Like, yeah, like I'll look at what other people are doing so I don't get treated
Right.
like, because when I'm myself, I get treated very poorly.
Right. Like it's an adaptive skill that they've developed for safety a lot of the time.
Yeah, or a longing to connect, like something is keeping me from connecting with someone.
Right.
Hmm.
But it can also leave them feeling like they can't be themselves around anyone ever. And that, I think, is when some of the harm also plays a role.
I'm thinking about a client that I am currently working with who has ADHD. And has used the experience of masking or has said like there's trouble, and I know like ADHD is not even the same thing as autism, obviously, but I don't know a ton about like the major differentiations, but like they struggle with expressing and communicating feelings, and they have stated to me that it's like, oh, I've been like masking so much that I don't know my own feelings. And that's been kind of an area where it's like, I would love any perspective that you have on that. And I know even for me, it's like, oh, this is like really challenging, right? Like, are you struggling to connect with your feelings and communicate them because of like some of the many reasons that like in particular it's like a cis male, right? Like we don't really teach cis males to understand their feelings. But the experience of like the masking being part of that has, you know, been more difficult for me because I don't have as much experience working with folks who like maybe can't access their true emotional experiences, or like have been masking for so long in certain areas that there's actually kind of a bit of like an identity crisis even. So yeah, I would love your thoughts.
Yeah, I think the first thing I would say is autism and ADHD do actually have quite a bit of overlap. The odd ADHD is the acronym for it. Community is people who have both things, and it can be really complex. I think my approach is generally working with them to find ways to safely experiment, maybe with allowing themselves to express whatever it is that comes up in the moment, and trying that on, seeing how it feels. Does it feel relieving? Does it feel weird? Does it feel stressful? Does it feel awkward? To not try to suppress, or to be in an environment or with people who you know will just accept. I think that's a lot of the benefit of finding community, whether in like something like group therapy or support group, or just showing up to like a place or an organization that is for autistic people or ADHD, speaking with them, sharing experiences, realizing that what they're experiencing is not all that different than maybe somebody else has experienced, and that it's okay to say something that maybe in a different space is really isolating or might get them rejected. I think probably somebody like that, I would really be working with them to find community. I think the only thing I have left is, you all asked a little bit about treatment interventions. I think my biggest tools are normalizing their experience, not reacting in probably the way that they experience from everyone else. People will tell me something like, I don't know, I'm trying to think of an example. I don't know, they'll tell me something and I'll be like, yeah, of course you did. Like, yeah, that makes sense. Or kind of just normalize it and be like, yeah, I can see why you would do that. Or I understand, like, that makes a lot of sense that was your reaction. And that is sometimes the first time that's happened. It's they're like have a lot of distress about that different reaction that they naturally have. And for somebody to just be like, yeah, I mean, yeah, that makes sense. Or to be able to say like, yeah, I have other people that have shared that that's how they experience that. You can kind of like sometimes see like the excitement in their eyes of like, what? Okay. And it'll kind of facilitate a little bit more sharing. And I get a lot of like, okay, this happened. Why did I do that? Like, okay, well, I wonder if it's maybe this. Had somebody come to me last week, maybe, struggling with, they're one of the ones who are struggling with alexithymia, and they were like, I cried when Spider-Man did this in this movie. Why did I do that? I'm like, well, okay, let's piece that apart. Let's see what's going on. But really it's just kind of like normalizing that experience of, that's not weird. It's just what you did. Like, let's understand it. Exploring internalized ableism, I think, is also a really, I guess, technically an intervention. It shows up a lot. There's a lot of learned narrative, I think, is how I would describe it, of this thing that I do is weird. This thing that I do is wrong. This thing that I do is not okay. And that makes me weird. That makes me different. That makes me any number of things. Stupid, I've heard a lot of different things, and gently pressing them on that, and offering an alternative of that. Maybe it's because this happened, or that's actually something that lots of autistic people talk about. That doesn't make you stupid. That doesn't make you weird. I think that more than anything is a really powerful intervention, and something that comes up a lot, especially in adults. They've got 30, 40 years of just not really being seen. And I think it's important to challenge those in a gentle way, so that they can start to begin to understand also some of the ways that they have taken on that like ableism view, and are like trying to force themselves into this this thing that doesn't feel good. Psychoeducation also, it's kind of intro level, but it's I find I'm doing it quite a bit, just because there are still a lot of misconceptions about what autism looks like, how it shows up. I still hear some of the like really old understanding of like a presentation of autism. It's just like one presentation of autism. So kind of like helping people expand that and understanding like, not every autistic person is like a savant, or not every autistic person flaps their hands, or not every autistic person like it looks different for everybody. That is why they originally used the word spectrum. So what does that look like for you, and helping them name that, or doing that with their partner or parent sometimes. And then also talking to, it's coming up more and more, especially with people having to go back to the office, autistic burnout, and why and how that's different for them, and why it can be so hard, why they're really struggling, just they're so depleted, and they just have not had the space to get back what they have given away for so many years. And then I think probably arguably one of the more important ones is just doing your own research, doing your own learning, asking great questions like you all did for this presentation. You don't need to know everything. Certainly I don't. But I think trying goes a really long way with this group, and just holding space for them is really, I think, some of the majority of the work that I do. That being said, there are some books that I have found that are pretty decent. This one has gone, let me see where I'm at. This one has gone around a couple of the autistic Facebook groups or like oriented groups that I am a part of. This was written by somebody, I think, want to say this is true, who is an autistic clinician. And they've adapted DBT skills for the neurodivergent community. So this can also be helpful with ADHD. If you work with teenagers, this book is a really great one. I find that anxiety is something, you know, especially of the social variety, is something that is a huge thing, and often what I'm actually treating, not. So this is based off of CBT, DBT, and ACT skills. Those are kind of like the places that I think I draw from the most when I'm doing skills-based work. And then this book is CBT adapted for, it's a little older, so it says autism spectrum disorder, but it is pretty decent as well. And then because some of my work is also around problematic sexual behavior, impulsivity, people who have gotten themselves into trouble in sex-related things, I also have this book. It's written for maybe adolescents, early adolescents, and it's kind of just helping facilitate the discussion around sexuality and relationships in a really accessible way, non-shaming way, neurodiversity-affirming way. So that's another good one. And then I have, if you all want, I have a couple of other lists of TikTok people and YouTube channels and podcasts and things that I have tried to vet for being affirming and from actually autistic people, and that kind of thing that I can share.
That would be awesome. We have a resource page, and that would be, yeah, if you can email those to me, and I can grab those books for the office guys, so you guys can use those too.
I think that's all I have. Any questions, anything that anyone wants to say?
Yeah, let's take 5 more minutes, guys, so we end at 12:50 for folks that have a session. But I just want to say that I'm so thankful, Connie, just for just such a warm, welcoming, loving approach even to this conversation. And it makes me think of, you know, when we were talking about, we talked about ADHD as a group and kind of this sense of the shame levels for someone with ADHD you know, comparatively are equal or can be higher than someone who's experienced incest, and just the impact of that kind of shame. And so it sounds, you know, really similar with the autism spectrum. So just, yeah, such a beautiful, normalizing, loving approach that I think sets a tone for us as we're, you know, as we're figuring out what's going on along with somebody. But Erin, were you raising your hand? Or yeah, go for it, guys. Okay.
Yes, so I have a two-parter question. One is about language, and the other one is about partners of someone, of autistic persons. So the first one is, I know that in the past, like the term high functioning used to be used. So I'm wondering, what is your take on that? Like what kind of language to use instead? And then the second question is, I do have several neurotypical women who are married to autistic men. And I feel like I'm trying to do a lot of grief work with them as far as coming to terms and trying to be in a space where they can be accepting and loving of their partners as it is. And there's a difficult pull of, I can so often feel them wanting to be like, okay, keep working on your skills so like you can conform to this neurotypical person. And so I feel like the question that they have so often is like, what can I even realistically expect as far as my emotional needs getting met? So I'm curious, I guess, what advice you have for the partners and some of that journey as well of even being affirming that, I mean, their brain is just different. Like that's how it's going to be. So I'm curious about your thoughts on both of those things.
That's a good question. First, the shift is going from high functioning to high or low support need. So the high functioning would have been, is now low support need, is the more affirming way to talk about that. I still get people who use that and I don't like shame them for it, but I don't use it. So I think after a while they get that why I'm doing that. That's such a complex question. That's very common. Your partner's experience, very common. I think my message is usually like, being an autistic person does not mean that you don't have emotions or empathy or that you don't want to connect. It's just learning, both of you working to learn how one another expresses that and how to meet one another's needs. And it's probably going to be different than you were taught. And it's probably going to be different than you expect. And then you have to decide if that's going to work for you. I think sometimes the answer, unfortunately, is no. They're looking for something more or different. That I've had a couple of couples that I've worked with. The partner, I think, unfortunately, because it just went on for so long and nobody knew what was going on. Like she was at the point that she was done. And we were having this conversation about like, yes, we can do this and we can all, and he wanted to, and all the things, but she was just done efforting essentially. And that's super sad. And I think that's really common, but the ones who stick it out, I think it's possible. And can be like super rewarding and their connection can be like amazing, just like anyone else's. It's just going to maybe look a little different. Hi, Amanda.
Yeah. I am just want to name that this is probably like a very specialty question, like a niche within a niche, but I work with folks who struggle with like disordered eating and eating disorders. And I was struck that during the training, I was like, yeah, I think a lot of the typical interventions that I would maybe like hone in, like probably are just not going to fit a person who's also has autism. And so I was wondering if you have like any kind of like info or research that maybe I could look into, but yeah, what your take is on kind of best practices there.
Yeah, this is not my specialty, but it is some people's, and there is a lot actually of overlap with anorexia specifically and autism. So there is research out there. I will try to include something in my list that I send you. But yes, I think it becomes a lot more complicated because of difficulty with like flexibility, that all or nothing thinking, and even like sensory issues and challenges. So the same interventions probably won't be as effective. And I think either learning them or understanding that you don't have that skill is, probably the best place to start. But for sure, if you are into learning, I think there are a lot of people who would really benefit from that. And I would refer to you often.
Thank you so much. Yeah,
Yeah.
I had a feeling that it's just like, yeah, this like really niche area, unfortunately. Yeah.
Mm-hmm.
One last question, anything before we close. Connie, or Dr. I'm sorry, I'm calling you by your first name and you're a doctor, Dr. Zollner. Want to honor that and all that hard work. But for people referring to you, are you taking patients around anything specific right now? I know you're busy, but
Yeah, I, especially if it's a direct referral, will find the time in the room. I don't often work with couples, so I think that's probably the only thing that I'm letting go of for sure. But anything else, adults especially, I think they're having a little bit of a hard time finding clinicians who understand and specifically specialize in working with adults. Mhm.
awesome. Well, amazing works. Thank you so much for just coming and taking so much time with us. I know it's, there's Amanda, you're not the only one that I think has niche questions to follow up on from this. But yeah, thank you so much. And then I'll share with you guys and to the team the resources she sends over, so we can kind of keep digging in. But
And please feel free to reach out. You'll have my email. Feel free to share it, Rachel. Like, I don't mind. This is a passion area of mine, so I'll take the time to write you a response.
thank you so much. Amazing.
Yeah.
Wonderful. Well, everyone, have a great weekend. I'm going to end the recording actually. And